Thank you, Ray and John Fred, and thank you to CCFA for this opportunity to present on this topic. So today I'm going to talk about the use and misuse of endoscopy in Crohn's disease, and Dr. Lichtenstein will be following and talking about the same with ulcerative colitis. I think it's a great topic. So Crohn's disease is characterized by chronic inflammation of any segment of the GI tract. The involvement is typically transmural versus the mucosal nature of ulcerative colitis. And what's really important is that the ileum, the terminal ileum, is most often involved, followed by the colon, and an ileocolonic or ileocecal pattern is often seen. But importantly, there are areas, especially in the small bowel, that are very important to get at, especially with kids. So the jejunum is involved in about 20% of cases of pediatric onset Crohn's disease, whereas only 5% of adult onset Crohn's has jejunal involvement. And the upper GI tract is involved 5 to 10% of the time. So as you can see, the involvement can be rather extensive. Endoscopy has the unique capability to examine the mucosa from the mouth to the anus, and it is the standard of care in Crohn's disease assessment. Endoscopy facilitates simple and innocuous tissue sampling at many sites in the GI tract and offers the potential for various therapeutic interventions. Endoscopy in Crohn's disease includes esophagogastroduodenoscopy, push enteroscopy, colonoscopy, flex-sig or limited colonoscopy when a limited exam is sufficient, single and double balloon enteroscopy, small bowel capsule endoscopy, ERCP, occasionally EUS, and some newer platforms as well. Endoscopy in Crohn's disease is the standard of care for the initial diagnosis, biopsy confirmation and clarification, assessment of extent and severity, postoperative disease monitoring, dysplasia surveillance, endoscopic therapy, and monitoring of mucosal healing or treat to target. Let's talk about gastroduodenal Crohn's disease. It's not common, but it's not rare. And a number of cases may have visually normal mucosa, or there may be mucosal edema, focal or diffuse redness, nodular lesions, erosions, ulcerations, friability, and strictures. And these images depict a case of a young man with gastroduodenal Crohn's disease. And the prepyloric antrum is on the left, and there's really very little abnormality that's apparent. I mean, there were granulomas on biopsy, but minimal erosive change, a little inflammation. But what is interesting is that the pylorus is fixed and is patent. It doesn't open and close, and that's from the chronic inflammation that has occurred either in the stomach or maybe in the duodenum. And on the right, you see images from the descending duodenum, and there are multiple ulcers seen. There is bridging, sort of pseudodiverticulum, and the thing that's, I think, most interesting about gastroduodenal Crohn's disease is often the ulceration and the look is very atypical. It's not your classic peptic ulcer disease. It's not your classic NSAID pattern, but there's often deformity along with the ulceration. So in the colonoscopic assessment of Crohn's disease, there again may be no abnormality, and yet biopsy will show granulomas or cryptitis, but there is more often the presence of erythema, erosions, or ulcers. The simple endoscopy score for Crohn's disease may be used in the clinic to assess disease activity over time, more often used as a clinical research tool. And there's also the more complicated but more often used Crohn's disease endoscopic index of severity to assess the change in mucosal disease over time in clinical trials for Crohn's. The Rutgers score is the most commonly used postoperative score to assess and follow Crohn's disease, especially that after an ileal resection. So these images here show an aggressive ileocecal valve, nodularity, the lumen is narrowed. One's able to get into the TI, but really not advance because of the nodularity and ulceration present. The true stenosis is present. And in the same patient, the colon was involved extensively, and these are images from the transverse colon showing multiple ulcers. There's cobblestoning, erythema, and a pattern consistent with fairly aggressive, moderate to severe colonoscopic Crohn's. Now, these images depict the Rutgers score, which so there are 5 images here, and the left upper shows normal ileal mucosa. There may be erythema, but there are no ulcers or erosions, and this is a Rutgers I0 score. The middle image is an I1, where there are less than 5 aphthous ulcers. The third image is an I2, where there are more than 5 aphthous ulcers, but normal intervening mucosa. On the bottom left, an I3, which is ulceration with no intervening normal mucosa, and an I4 is the most severe form with severe ulceration and or nodularity, cobblestoning, and stenosis. The Rutgers score is the best predictor of postoperative Crohn's disease course. It is based on ileocolonoscopy findings at the neoterminal ileum 12 months after ileal resection. A Rutgers I0 or I1 indicates low risk of recurrence, low risk of need for surgery, whereas a Rutgers I2, 3, or 4 defines high risk for a surgical outcome, and accordingly, treatment must be escalated, and annual or closer interval colonoscopy should be performed. This algorithm depicts a treat-to-target strategy using colonoscopy as the tool and mucosal healing as the target, and is a paradigm that is being increasingly used in Crohn's disease and other conditions. This is a patient from my clinic where sequential mucosal healing was identified over a period of several years using a treat-to-target strategy, optimizing his clinical care that happened very quickly. Went into clinical remission, but there were continued colonoscopic ulcers in the colon seen, but with anti-TNF optimization and additional strategies, ultimately, as you see in the bottom right area in 2013, complete mucosal healing has occurred. This slide depicts recent ASGE guidelines for tissue sampling in inflammatory bowel disease. So 2 scenarios are depicted here. One is for initial diagnosis, and one is for surveillance. So up at the top, a tissue sampling for initial diagnosis. At ileocolonoscopy, one should take 2 or more biopsies from each of 5 sites, and that should be at a minimum the rectum, the rest of the left colon, transverse colon, ascending colon, and then terminal ileum. And I typically get separate biopsies from the cecum and ascending colon, and separate ones from the rectum, sigmoid, and descending colon as well. Now, if upper endoscopy is performed for suspected IBD, then 2 or more biopsies should be taken from the esophagus, stomach, and duodenum. And again, the more the better. The more samples you take, the more information the pathologist can share. Now, for surveillance for dysplasia, all endoscopically visible lesions should be sampled, either biopsied or removed. And then there are two approaches to use. One includes chromoendoscopy, and I'm not going to get a lot into chromo. Dr. Lichtenstein will be addressing that in the ulcerative colitis segment. But the other approach is the standard 4-quadrant biopsies, and for pancolitis, one should take biopsies 4 quadrants every 10 centimeters from the cecum to the rectum with a minimum of 33 biopsy samples, and if it is non-pancolitis, then 4-quadrant samples of every involved segment should be obtained. This is a recent paper that depicts the fact that terminal ileum skipping may occur in Crohn's disease. And in this study, there were about 180 patients with Crohn's disease of the small bowel, and 153 of them had ileoscopy. 67, or over half, had a normal terminal ileum. 36, again, over half, had active Crohn's disease based on a reference standard for disease activity. And of these, 11 Crohn's disease patients had active disease above the terminal ileum, but again, no TI involvement. And these were mostly identified by capsule endoscopy. This next piece is very interesting, and that's the fact that 23 Crohn's disease patients had isolated active intramural or mesenteric disease, but no involvement of the TI. And then 2 patients had upper GI Crohn's disease identified at upper endoscopy. So here's a case study, a 42-year-old male, and again, this case is courtesy of John Layton. Recurrent abdominal pain and small bowel obstruction with negative CT scans. Presented in March of 2012 with abdominal pain and black stools. EGD, negative. Negative colonoscopy and ileoscopy with biopsy. Negative MR enterography, but positive capsule. And on the left, you see the white ulceration on the still image. And if I could have the video, please. As you see, there's some retained contents in the small bowel due to some distal stenosis and narrowing, but you see the white ulceration, the inflammation, the edema, and all of this, again, was missed on CT enterography, MR enterography, and only picked up with capsule study. This is a recently published prospective multicenter blinded study comparing capsule endoscopy versus small bowel before ileocolonoscopy. And what was found in the 80 patients included in the analysis was that the diagnostic yield of capsule endoscopy was equivalent to that of ileocolonoscopy in assessing the ileum and cecum. And the diagnostic yield of capsule endoscopy was superior to small bowel follow-through for evaluating the small bowel. 11 new diagnoses of Crohn's disease were made by capsule endoscopy alone, and 5 new cases diagnosed by ileocolonoscopy alone. So this clearly shows a role for capsule in suspected Crohn's disease. Now, deep enteroscopy can be achieved using double balloon enteroscopy, single balloon enteroscopy, and spiral overtube enteroscopy. And it's important to keep in mind that there are forceps channel which allow biopsy and therapy, allowing for interventional procedures. This slide is a recent summary, a review of 13 studies including 347 patients with benign Crohn's disease-related strictures. 66% had ileocolonic and anastomotic strictures, and 13% colon strictures. Dilation led to 86% technical success and 58% long-term clinical success, which is pretty impressive, but 42% of patients ended up needing surgery. A stricture length less than 4 centimeters led to optimal results associated with surgery-free outcomes. Importantly, there was a significant perforation rate, especially in 2 sites who had 2 reports with perforation rates over 10%. They mention that steroid injection and needle knife cut may increase the success in treating recurrent strictures. Can I have the video, please? So this is actually a video from a series of patients just reported by Payne and Beauchene in this month's gastrointestinal endoscopy, and shows balloon dilation of a refractory Crohn's disease small bowel stricture. And in this paper, which you all should read, remarkable success is reported. Dr. Shen is very talented, and this slide also depicts the use of the needle knife for, in this case, sinusotomy, where he opened up a narrowed stenosis on the left with the needle knife, and the result is seen on the right. And so one can perform sinusotomy or strictureotomy very effectively if one has these skills. Okay, this video depicts another problem where a small bowel stenosis led to capsule retention. Next slide, please. The use of the double balloon enteroscope, and again, these slides are courtesy of Jonathan Layton. This shows the retrieval of a retained capsule endoscope using double balloon enteroscopy and a basket, and this prevented the need for surgical resection or any surgical procedure. However, if one will use a patency capsule before capsule endoscopy, or perhaps alternate imaging measures such as CT enterography or enterography, one can prevent the need to have to retrieve a capsule. And this slide depicts a retained patency capsule, and that's okay, because a patency capsule is just a barium capsule which melts down after 30 hours and doesn't create symptoms in virtually all situations. But as you can see, where's the pointer? As you can see in the pelvis, there is a white density right in the middle of the pelvis, and that is the retained patency capsule, and that could be in the small bowel, or it might be in the rectum. One's not sure, but having retention of that capsule is a positive study, which means one shouldn't go ahead with the capsule endoscopy unless one is sure that it has passed through the ileocecal valve. So I went ahead and did a CT scan immediately after the abdominal film, and that did demonstrate that the patency capsule was in the terminal ileum, and capsule endoscopy was not performed. So what about the misuse of endoscopy and colonoscopy? Well, some examples are doing endoscopy outside of accepted indications, certainly outside of a carefully planned clinical trial. It would also include assessing inflammation without taking adequate biopsies, not biopsying the correct location. So again, one should biopsy the edge of an ulcer and not the center of an ulcer. That would be a good example. Not taking a sufficient number of biopsies when performing surveillance, not putting biopsies of suspected dysplastic lesion and surrounding normal mucosa in separate containers, doing full colonoscopy when FlexSig or a limited colon exam is sufficient for the clinical situation, balloon dilation of a stricture more than 7 centimeters, which is typically not successful. Repeated balloon dilations over a short interval. Failure to screen for strictures before capsule endoscopy. Performing advanced endoscopic therapy without appropriate training or experience. And performing colonoscopy or capsule endoscopy for suspected Crohn's disease without sufficient criteria. And these criteria might include items such as this, and this is from a recent paper by Gerson, listing criteria for obtaining capsule endoscopy in a patient with suspected Crohn's. The same criteria would likely fit for doing colonoscopy for suspected Crohn's, and that would be 1 criterion from group A, which would be abdominal pain, diarrhea, or weight loss, and then one criterion from group B, C, or D, and that would be either the extraintestinal manifestations from group B, inflammatory biomarkers from group C, or abnormal imaging in group D. What about the future? Well, I think the future is bright in inflammatory bowel disease and in endoscopy for IBD as well. Possibilities include a steerable capsule with biopsy potential, a colon capsule, or more likely a combined small bowel and colon capsule. High-definition endoscopy that will provide better images, magnification up to 150-fold, virtual chromoendoscopy, which will be an even better advance than our current narrowband imaging, and perhaps confocal laser endomicroscopy, which is high-resolution microscopic images visualized at subcellular resolution and examined in real time. The future may also include the integration of colonoscopy findings, such as mucosal healing, into a new Crohn's disease activity score. Certainly, treat-to-target strategy using endoscopy, colonoscopy with targets of mucosal healing, deep remission, and others will be part of the future. Ladies and gentlemen, thank you very much.